All right, today we're going to talk about neurological emergencies. The first lecture will be just general neurological emergencies, the concepts that apply to all of the emergencies. And then in the next few days, we'll go into a specifics of certain some types of neurological emergencies. But today, we will just talk about neurological emergencies in general. Sorry. So neurological emergencies, you have two components here. One is emergencies and one is neurological. What does the emergency component mean? That is, that means you have very limited time, very limited information, and generally, most of the time, you're dealing with some life-threatening, very serious situation. Usually people who have suffer from neurological emergencies, they're brought in uh, by ambulance or by neighbors, or majority of time they are in coma or they are altered, agitated, lethargic, so you cannot really get information from them. And again, you're dealing with a situation that time really matters. So you have to act quickly with limited information. And that's what makes the emergencies uh, interesting or appealing to some people like me. The neurological component of neurological emergencies means that you're dealing with a very high functioning organ. Brain and the nervous system are very high functioning organ that the slightest damage to this organ can have serious consequences, right? Whether it's ability to talk, to comprehend, to move, any any even small damage to the nervous system can have serious consequences. So you're dealing with a high functioning organ, which is at the same time very finicky. Brain has very limited ability to deal with distress. For example, if your blood sugar goes down, your most of your organs are able to burn fat or sometimes protein and create calories, create energy. But brain is solely dependent on glucose. Brain is very sensitive to any change in perfusion. So anything that the the stresses that other organs can handle to certain degrees, central nervous system generally cannot. So you're dealing with an organ that is very susceptible to injury due to distress. And of course, as you know, neurons cannot heal. So any damage to the brain tissue, to the nervous system, is uh, most of the time permanent. Another element that causes complication. These are the five things that your brain cannot handle well. Can you name those? Sugar. Very good. Brain is sugar is the main source of energy for the brain, and if you don't have sugar, brain cannot handle it. What else? Pressure. Increased brain cannot handle increased pressure. What else? Oxygen. Thank you. So hypoxia, brain is very sensitive to hypoxia. To a certain degree, but it's not the top five. What's the first one? Your brain sits in the calvarium in the skull. There's limited space in there. Brain does not like roommates. Anything in the brain other than brain is causes distress, right? Whether that's hemorrhage, whether that's a mass, whether that's metastasis, anything in there, brain cannot handle it, right? There is limited space, and brain does not like to share. And the last one is time. Brain is very sensitive. Any distress to the brain has a time stamp on it. As the time passes, the injury it becomes more and more irreversible. You've all heard the term um, time is brain, right? The, there's no other organ in the body that is as time sensitive or sensitive to time during injuries than brain. By every I read this number that by every minute of ischemia, for example, millions of brain cell dies every minute. So you have to really be quick um, to reverse the injury or the insult. Otherwise, the brain injury is going to be permanent. So similar to the previous slide, these are the things that can cause neuronal injuries. That's lack of nutrition. We mentioned uh, glucose, hemorrhage. How does hemorrhage impact the brain? One is by the cell death when you have ischemia from a brain bleed, the brain cells die, but also more damage is done by the size of the hemorrhage, the volume of the hematoma. As the hematoma grows, puts pressure on the rest of the brain, less space, more pressure, badness happens. Ischemia from decreased blood flow, any anything that causes decreased perfusion to the brain, whether there is a heart attack, whether there is an embolus, a thrombus, or shock, anything that decreases the blood flow to the brain can cause damage to the brain. Inflammation, hypoxia we mentioned. Inflammation, can you name some inflammatory processes that can damage the brain? Encephalitis, right? Encephalitis means brain inflammation. Um, Chickenpox. Meningitis is a type of inflammation and infection, correct? So any type of anything that causes inflammation in the brain can cause damage to the brain. Prolonged excitation. Example, when you're can you speak? Tetanus, yes, very good. And seizures, right? Seizures uh, uh, is seizure is a kind of prolonged excitation. Tetanus is almost like a seizure. Tissue damage from trauma, people who have traumatic brain injury, they lost tissue because of the trauma, and cytotoxic substances. Some examples would be um, like lead. Lead damages the brain. Botulinum toxin, it damages the brain. So these are the list of some of the things that can um, damage the brain. The general management of neurological emergencies, obviously, you don't want the patient to die, but also you want to preserve the neurological function. I put these two here because there's a kind of existential question always. What's your name? Anusha? Anusha, if you have a choice between dying or being bedridden for the rest of your life and disabled, which one do you pick? Rather die. Die? Anybody? Anybody else? So you see, it's a tricky question because for us as healthy people, it is easy to say, I rather die for obvious reasons. And actually, most patients who are in that situation also prefer death over being disabled, but less than healthy individuals because you really need to be in that situation to answer that question, right? You have to be in that situation, and so some people might choose living, but you have to be very careful um, when you're treating people, sick patients, sometimes what you do can um, cause them to be disabled for the rest of their life if you do too much. For example, if you're doing cardiac resuscitation, when at some point you need to, and this is probably one of the hardest thing that in emergency medicine, hardest decision that you have to make, that at some point you say, am I doing harm to this patient by bringing the heart back, but letting the brain die? So you're bringing someone, you're creating a vegetable, someone who the rest of their lives are going to be dependent, right? The balance is extremely tricky. It's a really difficult situation. And in neurological emergencies, because again, you're working with people with brain, a high functioning organ, at some point you have to make a choice that is it better if I let this patient die, or should I continue keeping him alive but bedridden with no function, right? Keep that in mind. It's again, this is when you work with a central nervous system, this is always um, an issue. Again, this is an issue of death or dependence. And this is the study that I mentioned. They surveyed people who had severe stroke, and they asked them whether they want to live or die. And 69% of patients with a stroke, they chose death over disability, and 82% of healthy people who were said the same thing. Again, this is uh, a question for patients to answer, not for us, even though we have preferences, but unless we are in that situation, you can't really say. In there are several ways to measure the level of dependency in neurology. The most validated system is Modified Rankin Scale, and it starts from MRS of 0 to 6, which is death. Um, and some people argue that 5 is probably worse than 6, as we talked. So as the level of disability increases, you go from some mild symptoms but no disability, slight disability but you can still live independently, moderate disability that you can live with some help, moderately severe. This is how we measure how that this is how we measure neurological function. And most studies that uh, assess an intervention to see whether that intervention works or not, for example, in the stroke or in other neurological diseases, the optimal outcome is 0 to 2. Sometimes they consider 3, but these you want people to you want any intervention that you do to bring the patient into 0 to 2 and not higher than that. So what can kill a patient with neurological emergency? Can blood loss kill in neurological emergencies? Yeah, can it? So if you think about it, if you're talking about brain, right? Uh, that's just how much blood can you lose in your brain, given that limited space that there is? You cannot bleed too much in there. The bleeding can kill you, but not just because of the amount of blood that you lose, because the brain is a limited space. At some point, the pressure is going to, the pressure built up inside the skull is going to stop the bleeding. So there's really not much room in your brain for you to bleed to death. That's opposite to in your in the abdomen. In the abdomen, you can bleed liters of blood because there's a lot of room. There's not much constriction around it, and you can bleed a lot. In your pelvis, people with who have hip fracture, sometimes they can bleed up to 3 liters of blood in their pelvis because there's a lot of space. In the brain, there's really not much room to bleed. So the people usually don't die from blood loss. They can die from consequences of the the hematoma, the size of the hematoma, the pressure built up in the brain, but not purely from the amount of blood that they lose. Any injury to the brain, just like the rest of the body, can causes swelling, and swelling causes the pressure inside the brain to go up, and brain swelling is probably one of the worst outcomes of any neurological emergencies because it has serious consequences. Increased intracranial pressure could be from swelling or could be from other causes. What happens in when the blood when the intracranial pressure goes up or when brain swells up, it puts pressure on the parts of the brain, especially midbrain, that control the breathing, right? So you can have a hematoma, you can have brain swelling, and that is going to affect how they're going to affect the respiratory centers in the brain, and it can stop the respiratory drive, and you can stop breathing. But also remember that brain controls the cranial nerves that manage your secretions, your swallowing, your speech, and you won't be able to manage your secretions. And lastly, some of the neurological emergencies, such as the status epilepticus, they cause cardiopulmonary arrest. So people who are seizing for a long period of time, they can stop breathing um, as a result. In trauma, we have a triad that they call the trauma surgeons who love fancy, impressive terminologies. They call bloody lethal triad. And that's a combination of coagulopathy, acidosis, and hypothermia. Acidosis happens as a result of ischemia, right? That's in you're talking about uh, uh, trauma in general. Um, Tissue damage releases thromboplastin in the blood, and that can cause coagulopathy. So you have a patient who is suffering from severe trauma, they already have hemorrhage, and then tissue damage releases thromboplastin and it promotes more bleeding. So you have to be very aggressive with controlling the bleeding, otherwise the coagulopathy resulting from the trauma can cause more damage. And then hypothermia causes acidosis and coagulopathy. So it's a vicious cycle. In the brain, the acidosis and coagulopathy um, do the same type of damage, but hypothermia sometimes come handy, especially in traumatic brain injury, because it reduces the the brain metabolism. And when the metabolism is decreased, it will help the brain and reduces ischemia. But regardless, this triad for the in general in trauma is extremely dangerous, and the early damage control, which means control the bleeding first, prevents these cycle to occur. So just like every other emergencies, in the emergencies, we always go by ABCD, right? A stands for airway, B breathing, C is circulation or perfusion, um, D is dextrose and disability. So for managing the airway, as I said, in neurological emergencies, you lose your ability to control your secretions, you lose your ability to swallow, and therefore, and then as we said, the damage to the brain can cause damage to the brain parts of the brain that control the breathing, and therefore you can have airway compromise. Uh, Sometimes you have to do intubation early to secure the airway. It's either when there's too much secretions that patients cannot handle and they're hypoxic, and you don't want the hypoxia to cause more damage to the brain. You have to intubate. Sometimes you see a large bleeding in the brain, and you know that this is going to result in brain herniation that we'll talk about, and it could cause respiratory arrest. And sometimes you have to make a decision to secure the airway before that happens, because in emergency medicine, we always prefer elective intubation over emergency intubation. You do the intubation, you kind of predict that you're going to need intubation. You do it early. You don't want to wait until patient stops breathing, and then you have to rush everything, right? So if you have any serious brain condition that you predict that this could end up being a respiratory emergency, it's better to intubate early, secure the airway so you don't have to worry about hypoxia or any breathing related issues. Suction is your best friend in a lot of patients who have seizure, patients who have traumatic brain injury, patients who have all sort of neurological emergencies. Again, I emphasize that they lose their ability to manage their secretion. So you always have to suction them, and a lot of them, many times, just suctioning them improves your oxygenation, increases your oxygen saturation. Oxygen, of course, comes handy, but more and more research is coming out these days that giving patients unnecessary oxygen actually can be harmful. So only oxygen if they are hypoxic, right? Usually less than 95% or less than 90%, you put them on oxygen. If they are not hypoxic, they might not need oxygen. So we moved on from and now we are talking about circulation or perfusion. We have to ensure that during the resuscitation, the brain gets adequate perfusion. And that usually means a map of 80, at least 80. Managing blood pressure in patients who have neurological emergency is tricky, because if your blood pressure is too low, the it can cause ischemia. If it's too high, it causes cerebral vasoconstriction and more damage to the brain. So you have a very narrow window. You have to be very careful. What um, brain is more sensitive to is sudden moves in blood pressure. So if you go from a low blood pressure to a very high blood pressure too quickly, that damages the brain. Or if you bring the blood pressure too fast, it can be harmful. But in general, the rule of thumb is you want a map of at least 80. Cerebral blood flow refers to the rate that arterial blood delivers oxygen to the capillary bed in the brain. The the numbers, of course, these are arbitrary numbers, but usually the normal pressure is between 50 to 100. When you get close to 20, you're facing ischemia, and then if it goes below 20, close to 10, that's when you face tissue death. D stands for dextrose. Every patient with any kind of neurological symptoms need a blood sugar. This actually can save a lot of patients from a lot of interventions or tests or anything, because they present in with altered mental status. They even have focal neurological deficit. You check the sugar, it's 20, give them 2 amp of D50, they come back to normal. So always check the sugar. You check their GCS. It's important to do the Glasgow Coma scale, because you can determine what intervention they need. Do they need intubation? Do they need other interventions? And then you can monitor the GCS to see if you're improving or not. And for people who are altered or present with any kind of neurological symptoms, consider naloxone. Um, uh, where I work, we have a lot of patients who use heroin, but actually right now the uh, s- um, Opioid overdose has become extremely prevalent because of the synthetic fentanyl. Synthetic fentanyl, there is the most people have very unpredictable response to fentanyl. They don't really know um, what they are taking, and it's mixed with usual heroin. So you can have fentanyl mixed in heroin, fentanyl with mixed with other drugs, and then they can have drug overdose. And it's always a good idea to try naloxone. And of course, thiamine is for people who have ETOH abuse. The neurological exam, obviously, you check the mental, you check patient's mental status. Are they alert oriented times three? Are they confused, lethargic, in coma? Mental status is important. Then you check the motor function, sensory function, cranial nerves, and brainstem functions. Consciousness is a two um, system entity. The arousal or being awake depends on, is controlled by brainstem. It's a primitive function, but awareness, the orientation is something that's controlled by cerebral cortex. In emergency medicine, observing the patient gives you so much information because you don't generally, as I said at the beginning, you don't have a lot of information, other information. They don't come with the relatives or they don't come, a lot of them cannot talk, they cannot provide information. So what you have most of the time is just observing the patient, and it can tell you a lot. In our um, board examinations, when we have oral board exam, one of the first questions that they teach you that you should be asking is, what does the patient look like? And that information gives you a lot of information. The patient looks in distress, it looks agitated, it looks disheveled, unkempt. These are how the patient looks is can give you a lot of information. In neurological emergencies, position of the patient. Are they having flexor contractions or extensor contraction? Your eyes can give you tons of information. The eyelids, the size of pupil, the reactivity to light, the eye position of the eye. Does the patient have a gaze? Um, the extraocular movement. So from your eyes, you can get a lot of information. Involuntary movement usually indicates seizures, agitation. Why would a patient, what are the common causes of patients being agitated? Why would someone be agitated? Pain, very good. What else? Stress, okay. Medical conditions, although stress is a medical condition, but yeah. Intoxication, what else? Ammonia level, usually they become uh, the comatose. Yeah. Two things can cause for us the two emergencies. Hypoxia is can cause agitation. It's kind of it's very common for patients who are hypoxic to be agitated, and any patients who is agitated, one of the things that you have to consider is this patient hypoxic? And also brain injury, any kind of brain injury can cause agitation. I had recently I had a patient who was extremely agitated, combative. He was in an altercation, and they brought him. He was all bloody, and we wanted to get a CAT scan, but he wouldn't stay on the CAT scan table. He was threatening to kill the technician, and they sent him back, and they said if he can threaten us, he doesn't need CAT scan, he's fine. And finally, we sedated him. We got a CAT scan, and he had every kind of bleeding in the textbooks in his head. He has subarachnoid hemorrhage, he has subdural hemorrhage, epidural hemorrhage, intraparenchymal hemorrhage. Any kind of brain injury can make you agitated. So people respond differently to brain injury. Some people go into coma, they become lethargic and confused. Some people go the other way, they become very agitated. So these are the things that you have to consider, that any change in mental status could be an evidence of brain injury. And especially hypoxia can be a cause of brain injury. Obviously, speech, you check the skin. What does the skin tell you? I think he mentioned dehydration. If you're dehydrated, your blood pressure drops, the perfusion to the brain drops. But most importantly, skin tells you about how your brain is being perfused. If your skin is cold and clammy, you already know that the perfusion is compromised, and therefore brain could be suffering from uh, hypoperfusion. But if the skin is warm and is not cold and clammy, then you know at least the perfusion could be uh, maintained. Mental status is one of the most sensitive tests for perfusion. When you go, excuse me, when you go into a room and you talk to your patient and ask their name, introduce yourself, ask them to introduce themselves, ask a few questions. If they're talking to you calmly, comfortably, accurately, the brain perfusion is restored. So the basic conversation, that 2 seconds of talking to the patient, can give you a lot of information about brain perfusion. So brain perfusion is intact if patient is able to talk or can provide information. And of course, you have to look for signs of trauma. Yeah. Again, we mentioned that brain time is everything in neurological emergencies. So every question, every information that you can collect about the timing of events is going to help you. When did the symptoms start? How long did it last? When was the last time the patient was seen normal? This is a critical information, especially in the stroke. You want to know when was the last time that patient, somebody talked to the patient, someone saw the patient, and she or he looked normal, because that determines how long, how much time do you have to make to intervene, right? If someone was well talking before uh, they went to bed, and now it's 9 o'clock in the morning and they're not talking, you wouldn't know when this event happened. So you have to assume that it started that before going to bed. So you've lost a lot of time. But if somebody tells you that they called the patient at 8 o'clock in the morning, and then at 9 she was not talking, that's a useful information. Then you know that you have more room to maneuver, more time to intervene. So last well known is important. Exact timing of the events also is important. The chronological aspects of the events are extremely important. Usually they give you a lot of clues about what type of injuries you're dealing with. Something that happens suddenly is usually a type of hemorrhage. Something that happens over time, it could be a space occupying lesion, could be infection or other things. So how the timing of events again is extremely important. And then you look for clues or red flags. If the patient has s- systemic findings such as fever, that's a clue that most likely you're dealing with a CNS infection. If patient has history of HIV, it gives you a clue that the symptoms could be due to some sort of infection. What kind of brain infection do they get? One more time. They get meningitis. What else? What specifically they get that other people less likely to get? Toxoplasmosis. Um, and so they're a patient with HIV. They are immunocompromised, so they can get any kind of brain infection, including meningitis, encephalitis. But also they get some sort of parasitic infections that people with normal immunity usually don't get. The other signs, if the symptoms are triggered by cough or exertion, usually we are talking about the space occupying lesion. If change in the mental status is CNS infection, bleeding, mass lesion, neck exam. I forgot to mention that in you have to check patient's neck, look for to see whether neck is supple or rigid. That usually tells you this is from subarachnoid hemorrhage or meningitis. And just going back to the timing of event, the subarachnoid hemorrhage usually happens in young people, and it can be very devastating to the brain. But one of the things, one of the clues that you can get that may raise your suspicion for subarachnoid hemorrhage is what we call thunderclap headache. It's a headache that comes very quickly, very suddenly, and it's very severe. Then patients describe it as, they were sitting watching TV and they all of a sudden they felt like they were hit in the head with a hammer, or they were hit by thunder. It's sudden onset. In the past, we used to say, is this the worst headache of your life? But we have moved away from it because everyone who has headache, that's their worst headache of their life. But thunderclap headache now is a very highly suggestive of subarachnoid hemorrhage. During anything happens during pregnancy or postpartum, it's usually sinus cavernosus thrombosis or pituitary apoplexia. If you look at the patient, if you do fundoscopy and you see evidence of papilledema, it can be a space occupying lesion, but also you can see it in CNS infections. Sudden onset, as I mentioned, thunderclap headache is suggestive of subarachnoid hemorrhage, and patients who have cancer, if they come with severe headache or altered mental status, is from mets to the brain. How does a metastatic lesion affect the brain? Two ways. One is it occupies a space, and as we said, brain doesn't like roommates, and it causes edema. So that for two reasons, by two mechanisms, metastasis to the brain can cause a neurological damage. What do you see here? Uh, no, these are if you're referring to these, um, you're referring to these. These are calcification. This is not bleed. But I want you to pay attention here. You see all this, the sulcus, the brain folds here, right? This is a normal brain. This is how the brain is supposed to look like. Here, all of those folds are gone, right? Even the ventricles are gone. It's because the brain has severe swelling. This is a cerebral edema. This is the CAT scan, and you can see there's a large mass here, and you can see it more clear in the MRI. What is this one? It's hemorrhage. What else do you see? Midline shift. And what else? you see a lot of edema surrounding it, right? So this is the tissue that is dead already. But then here, this is the cerebral edema. These are the cells that are could be salvaged. There's a lot of swelling, and your effort is basically to save the surrounding tissues and prevent the if you have that much midline shift is usually game over. Um, the problem with severe swelling or the having large hematoma in the brain is that it increases the pressure inside the skull, and then the brain has to kind of escape that pressure. And any opportunity, any space that is available, the brain is going to be pushed towards those spaces. If the patient has craniotomy, history of craniotomy, or in children that they have the sutures open, the brain is pushed through that space. But the most dangerous ones are when the brain herniates down towards the midbrain, because that pressure on midbrain can stop the patient from breathing. It's going to affect the breathing centers, and it's going to stop the uh, patient from breathing. So any increase in intracranial pressure can cause herniation and can have serious consequences. That's why you put a lot of effort in preventing the brain swelling, preventing increased intracranial pressure, because if the pressure stays up for a period of time, then you can have herniation and serious consequences. So this was the general topic, emergency neurological emergency medicine. Tomorrow I'll talk about traumatic brain injury. The next day we'll talk about the status epilepticus, and then the last day on Friday we'll talk about meningitis. Any questions? All right. Thank you very much. Have a good day.